So let's start with the talk of today. And today's topic, it was like we on at request of the trainees in my country, Pakistan, they asked me to present something along lines of overdose and toxicity. So so that's what we are going to cover today is like I think there are 11 things. Initially I planned for 9 and then I added 2 more. So one is kind of psychiatric assessment of an overdose of any tablets, and then paracetamol overdose, organophosphorus overdose and toxicity. Then I also added anticoagulants to this, and then lithium toxicity, benzodiazepine toxicity, tricyclic antidepressants toxicity, antipsychotic overdose, and NMS also I added as a topic. Psychostimulant overdose, benzos we have already mentioned. Then serotonin syndrome is another thing which we added, and there might be one more. So let's start with the thing. So whenever we are uh, assessing any case of the overdose or toxicity, especially the suicidal attempt, what are we going to check if a patient comes to the emergency department? So what should be our kind of scheme of checking? So first of all, we see that what did they take, how many tablets did they take, what was their intent, was it a lethal intent or not, did they really expect to die? Now, was it a planned thing or not? And if it was planned, what was the planning? Was the planning, like, what was the intent of planning? Whether it was planned or unplanned. Did they really want to die, or did they want to teach someone someone a lesson? And what did they want to do? Like so planning. Then preparation is another thing. So planning, how long they started planning, and then what preparation did they do? When did they start collecting the tablets or whatever thing they took, and uh, from where they collected top tablets, what were the actual tablets? So were they very lethal, and did the person really know that it was very lethal, or was something unlethal, non-lethal, taken with a lethal intent? The patient may think that he may die from an overdose of 12 tablets of paracetamol, or he may think that he will take 40 tablets of paracetamol and he will not die. So lethal intent of lethality is very important to determine performance. So, and then in performance, one thing to know is that whether the patient drank alcohol along with it or not. And then so precautions to avoid discovery. So whether the patient was alone at home, or if did he go to forest. If it may be that he tried to hang himself, shoot himself, jump into a river. Timing may be important. They tried to jump during the midnight when no one is there and they can successfully drown themselves. Or did they try anything in front of everybody? Or if they jumped into the river, it was a daytime. So all these things are very important, that what precautions were taken to avoid discovery. And then preparation, the other things, including preparation, maybe writing a suicidal note, and then uh, uh, making a will, making a bank transfer, etc. So all these things patients can do in this context. And then it is the uh, planning for future. How do they feel now? Do they think? Do they have a regret or a remorse? So do they have a remorse that why did they try to kill themselves, and they will not try to do that again? Or do they have a regret other way around, that why did it not work this time, and it should have worked? And what are their plans about the future? They want to die again, and they want to do something in the future. So planning for the future, it is important to determine. Presence of psychiatric illness. So psychiatric illness can be anxiety, depression, OCD, most commonly depression. And then personality disorder, very important, which will come in the piece later. Uh, and psychosis, sometimes psychosis is also present. Past and family history, psychiatric history in the family. Bereavement is also important in the social history. Past and family similar history, uh, a similar history that the patient tried to, like any of the family members of the patient tried to kill themselves in the past, and that could be a family history of the similar thing in the in the past. Past and family medical history. Has anybody died of a medical cause? Has anybody committed suicide? Has anybody uh, any medical condition right now, and patient himself suffers from the pain or not? Has patient done anything like that in the past? Personality factors, most commonly emotionally unstable personality disorder, but other personality disorders could be obsessive compulsive, perfectionists. So because anything if goes against their principles or against their standard of perfection, they may kill themselves. And uh, and then uh, conduct disorder and antisocial personality disorder, these are also linked with precipitating factors. So what were the triggering factors this time? What led to this attempt? Predisposing factors, all above: family history, personality, and ongoing social history, alcohol and substance misuse, etc. And perpetuating factors are also the same: presence of psychiatric illness, etc. Protective factors and supports in place, that's very important to determine whether the patients know that, are they living alone, or is he living with his family? Is the family very supportive or not? And are there any other supports in place or not? Is patient linked to the psychiatric community mental health team, etc. So uh, and then you determine the risk assessment, whether it's based on that you make your own analysis. It's a no risk, low risk, medium risk, or a high risk, or a very high risk. So now we come to the medical bit, or the go to the liaison psychiatry bit of that. So paracetamol overdose, and the our our objective, our aim of uh, of learning this is that, first of all, we know that what will be the symptoms of anything, especially the antipsychotic and antidepressant syndromes. and lithium toxicity, what are the symptoms so that we know. Secondly, when we go to assess someone in the accident and emergency department, we can look at the treatment, what treatment the medics have given. Although we are not providing that, but at least we'll know that something is being given, patient is medically fit or not, and uh, the same way. So we can look at these things. So paracetamol overdose, it is the most common in the UK and Ireland. So in the Western countries, people take usually paracetamol because it is available in the open market. Other painkillers are also available, and patients do take other analgesics as well. And also, patients sometimes think that it is inert and it may not lead to death. So it's, in patient's perspective, it is a safe drug, but in massive overdoses, it is not that safe. Patients have died due to paracetamol. Patients have resulted in fulminant uh, hepatic failure due to the overdose of paracetamol. So paracetamol is also called acetaminophen. Early presentations within 24 hours. It's likely to be asymptomatic within 24 hours, and uh, but like it is likely to be asymptomatic, but there can be some symptoms which can come within 24 hours, and one will be lucky if the symptoms emerge earlier on, or if the treatment is started, whether the symptoms come or not, if the treatment is started within 24 hours, the chances of survival are more, and chances of hepatic damage are less. So why I'm saying that patient may be lucky, because they may have a precaution to avoid discovery. They may not tell anyone, but their nausea or vomiting will tell. Lethal dose of paracetamol, I am not sure, but usually I've seen that patients with up to 40 tablets of paracetamol have survived, and it may be and the lethal dose may be different for different people, but I'm not sure about the exact figures. So so early presentation, so yeah, if the patient presents with symptoms, their household will know that there is something wrong, and they will bring the patient for the medical treatment, and the patient may tell the emergency department doctors that he has taken an overdose. That's why I'm saying that if the if the patient is symptomatic within 24 hours, he's lucky that the treatment can be started. Otherwise, treatment can be delayed, and that can lead to hepatic damage, acute fulminant hepatic failure. So late presentation more than 24 hours can lead to hepatic failure. Nausea and vomiting. So the patient may be lucky, but if the patient is asymptomatic and not treated, they may develop hepatotoxicity. Investigations you should do is LFTs, UNDs, paracetamol levels or acetaminophen levels, PT, IPTT, INR, just to indicate the liver damage or extent of it, and salicylate levels. Finger prick glucose, ECG, pregnancy test in women. Treatment is airway, breathing, circulation. Gastrointestinal decontamination with activated charcoal. Now we are from psychiatrists. I don't know what it means, but that is like equivalent to previously it was called like a gastric lavage. It is equivalent to that. You just decontaminate, and this is what is prescribed in most of the toxicities. Only in some toxicities it is not advised. So you do a gastric decontamination. N-acetylcysteine, NAC, that is given as an antidote to prevent further damage and to undo the damage. Slow IV infusion, 12 to 72 hours protocols, the sooner the better. Antiemetic therapy can be given for the symptoms, and prognosis is good with the NAC, N-acetylcysteine. Now the next one is organophosphorus overdose and toxicity. All symptoms, all symptomatic patients should receive therapy with oxygen and an oxime, pralidoxime, and benzodiazepine. Symptoms of organophosphorus poisoning. So organophosphorus are generally used as pesticides, I think, uh, or that's the use in Pakistan and possibly in India as well. The same. So and people may have real suicidal intent and expectation of dying, and then when they take it, it is often successful. So this is a cholinergic drug. So what it will cause in mouth, it will cause more of an acetylcholine, sialuria will be there. Then esophagus and stomach, there will be more acid secretion. Gut, there will be gut pains, diarrhea, spasm. Heart, what will do acetylcholine? It will slow down the heart rate, bradycardia, hypotension, and patient may die of it. Bronchoria, so increased secretion of from the bronchus. Bronchospasm, and again due to these things, patient may die if the airways are blocked due to excessive mucus, or if they due to the bronchospasm. And so bronchospasm may be there. Heart, we have seen the bradycardia. Bladder, so it should lead to excessive urination ideally, and that's what the sludge mnemonic is there. Sludge BBB, that is the mnemonic, and it's not made by me. It is the website I consulted, uptodate.com. They came up with this mnemonic. So salivation, lacrimation, urination, defecation, gastric emptying. So increased gastric emptying. And then BBB, bradycardia, bronchoria, bronchospasm. And respiratory insufficiency can result from muscle weakness, decreased central drive, increased secretions, and bronchospasm. Treatment is oxygen, intubation, avoid succinylcholine, and decontamination with activated charcoal, and then the next one is so adequate volume resuscitation with isotonic crystalloid, normal saline or lactated ringer solution. Atropine, because it is the cholinergic toxicity, so you are giving something which is anticholinergic. And then benzodiazepine therapy can also be given. Pralidoxime is given with atropine. Diazepam can be given, especially if there are seizures, but do not give anti-epileptic. Wherever we are coming across seizure activity in today's talk, we are not giving anti-epileptics, and it's not we. Please mute yourself. So we are not giving any anti-epileptic to anyone, and for, by the way, it's not us who are giving this treatment, it is the emergency doctors, but probably they will not be giving anti-epileptics. Now the lithium toxicity, that's the next topic. So early signs: nausea, vomiting, diarrhea. typical, but then neurological findings may develop, and which may include ataxia, dizziness, confusion. Tremors can be there, so ataxia, dizziness, confusion, and tremors. Chronic poisoning is sometimes there, and there could be acute and chronic poisoning as well. So sluggishness, ataxia, confusion, agitation, neuromuscular excitability, irregular course tremors, fasciculation, myoclonic jerks, severe lithium intoxication can lead to seizures, non-convulsive status epilepticus, and encephalopathy. Severe poisoning can cause seizures and non-convulsive status epilepticus or encephalopathy like delirium. Elderly patients are more at risk, and poisoning may stem from dehydration or decline in renal function. And then the dehydration and acute renal failure may be important contributing factors. Chronic renal failure and drug interactions may also cause it. Now, which drugs to avoid with lithium? It is very important that you should avoid certain drugs giving with lithium. Thiazide diuretics, it's an almost absolute contraindication. Ideally, you should also avoid giving loop diuretics, furosemide. Then, uh, and then the next thing uh, is so then the ACE inhibitors and ARBs, angiotensin receptor blockers. So these should also be avoided along with the uh, lithium, and then painkillers, Nsaids. So Nsaids should be avoided because and there is something, it's written in the Maudsley that if there are regular Nsaids along with that, you can give small dose of lithium as long as it doesn't result in toxicity. But this is not the case with angiotensin related antihypertensives. Even small doses should be avoided because it's a cumulative effect, and it can lead to a chronic kind of or a late onset lithium toxicity. So if you are giving ARBs or ACE inhibitors, the toxicity may appear in a number of months because it's a cumulative effect. So the lithium levels or lithium concentration will build gradually. So that's why angiotensin receptor blockers and ACE inhibitors should be avoided at all costs. And then the treatment is ABC supportive care, hydration, electrolyte restoration, and whole bowel irrigation with polyethylene glycol. And extracorporeal removal such as hemodialysis may be performed in some cases. Then we come to the benzodiazepine overdose, which is also very common in Asian countries such as Pakistan. So benzodiazepine overdose consists of CNS depression with normal vital signs. Usually the vital signs are not disturbed, and the reason like the medicine moved from barbiturates to benzodiazepines was a very good reason, because barbiturates, and we are not discussing barbiturate toxicity today because they are almost obsolete now, but barbiturates were very lethal. Any overdose of barbiturates, chances of survival were very little. It was very difficult to survive with barbiturate toxicity. But with benzodiazepines, there are more chances of survival. So severe overdose can cause respiratory depression and stupor or coma, and rarely they can cause death as well. So usually the supportive care alone is enough, but if the vitals are really getting disturbed, or if the patient is comatose for a very long time, then flumazenil may be given. So it's an antagonist of the benzodiazepine receptor, hence an antidote to uh, benzodiazepines. So it can reverse the benzodiazepines induced sedation, and flumazenil can also precipitate withdrawal seizures in patients who have developed a tolerance to benzodiazepines. So because it may result in an abrupt benzodiazepine withdrawal. So that is why, and it can cause seizures. That's why the role of flumazenil in benzodiazepine intoxication is controversial. So I will reserve in only cases where the unconsciousness and stupor, the medical stupor is very prolonged, patient is like GCS is very low, or or especially if it is causing respiratory depression and the patient's life is in danger, then we'll go to flumazenil. Otherwise, supportive care alone, along with adequate rehydration, may be okay. Now, in adults, recommended initial dose is 0.2 milligrams IV, given by a slow push over 1 to 2 minutes, and repeated doses of 0.2 milligrams to a maximum of 1 milligram can be given until the desired effect is achieved. Now, the next thing is anticholinergic toxicity. Now, we have gone through the cholinergic toxicity where everything was wet, wet, wet. Like if we go to the sludge BBB, so it was salivation. In anticholinergic, it will be dry mouth. It was lacrimation. Here it will be dry nose and dry eyes. And urination, it will be retention of urine. Defecation, here it will be more constipation. Gastric emptying, here it will be more bloating and constipation, and no acid usually. Bradycardia, here it will be tachycardia and anticholinergic toxicity. Bronchoria, so here it will be more dryness in the bronchi, and bronchospasm, here it will be more bronchodilation. So it will be opposite, something opposite. So anticholinergic, it is kind of more red as a beet, flushing, like there is a relative excess of noradrenaline, and there is a deficiency of acetylcholine, so it will result in cutaneous vasodilatation, dry as a bone anhidrosis, hot as a hair, so anhidrotic hyperthermia, so it will be fever and hyperthermia, blind as a bat, non-reactive mydriasis, so patient cannot see due to dilated pupils. So you think of everything as like adrenergic or anticholinergic effects. Mad as a hatter, so delirium, hallucination, confusion, these things can happen. Full as a flask, urinary retention can happen. So CNF effects may, like what they call as a mad as a hatter. So other CNS effects may be anxiety, agitation, dysarthria, confusion, disorientation, visual hallucination, bizarre behaviors, and delirium, psychosis, coma, and seizures. And sometimes there could be paranoia, especially if it is related with delirium. So tachycardia, dry mouth, constipation, urinary retention, dryness of skin, flushing due to vasodilatation. Treatment is airway breathing circulation, observation of asymptomatic cases, benzodiazepines, cooling measures can be given, and temperature monitoring. Again, it is the job of the emergency departments and the medics, but usually what they recommend is not, they don't recommend the paracetamol or other antipyretics in these cases. They are more happy with the other cooling measures such as cooling blankets or room temperature, etc. Antidotal physostigmine therapy, again, it is controversial. Now, the tricyclic antidepressant toxicity, which is quite related, and I heard that it comes in the Pakistani exams as a theory question, uh, because in the olden times that was very common, and even now some patients are prescribed tricyclics. And of course, tricyclic antidepressants are the best antidepressants in terms of efficacy. It's just the toxicity which can lead to death. Overdose can lead to death, and it's not, they are not safe in overdoses, and that's why their use is prohibited, and also due to side effects. If someone is tolerating the side effects and there is no risk of overdose, and the depression is kind of moderate to severe, then there is no harm in using tricyclic antidepressants, and they are definitely safer than MAO inhibitors, and there are no accidental risks as with the MAO inhibitors. So, tricyclic antidepressant toxicity, blockade of cardiac fast sodium channels. That's what happens. Antagonism of central and peripheral muscarinic uh, acetylcholine receptors. Antagonism of peripheral alpha 1 adrenergic receptors. Antagonism of H1 receptors like antihistamine activity, and then antagonism of GABA A receptors. So, what will be the clinical features? Be neurological features will be there: sedation, coma, seizures. Cardiac features may be tachycardia, hypotension, and conduction abnormalities. And then it may be anticholinergic features may be dilated pupils, dry mouth, absent bowel sounds, or otherwise constipation, urinary retention, as we discussed above. So, in addition to anticholinergic features, what we are seeing in tricyclic antidepressant toxicity is that we are seeing something like cardiac effects, tachycardia, uh, which is also anticholinergic, by the way, hypotension due to alpha blockade, and conduction abnormalities due to its effect on sodium channel. What it says, blockade of cardiac fast sodium channels. So that's why we see conduction abnormalities and dysrhythmias. So, in what investigations will we carry out in tricyclic antidepressants? One is ECG. You will do in all these cases. In each and every case, you will draw an ECG and look for the QTC prolongation and other parameters. Sometimes, if the QTC is so prolonged, it can lead to torsades de pointes, which is a subtype of ventricular fibrillation. So, ECG is must. Serum tricyclic concentrations do not help to guide therapy. You can only determine that there was a toxicity or not by doing the concentration, but it will not give you uh, much guidance for you to provide the therapy. Treatment is airway, breathing, circulation, oxygen, hypotension, isotonic crystalloid solution we can give, vasopressor we can give for to undo the hypotension, alpha adrenergic agonists such as neosynephrine or norepinephrine. These like the inotropic things can also be given. Conduction disturbances, so For that, you can give infusion of sodium bicarbonate because the fast sodium channels in heart are blocked. So you can give more sodium and in bicarbonate form, ideally. And gastrointestinal decontamination, you can give with do with activated charcoal. Seizures, they are treated with benzodiazepines. We generally do not, or the emergency clinicians generally do not give uh, anti-epileptics unless absolutely necessary, and do not treat it with phenytoin. And now the next topic is antipsychotic overdose and NMS. So my source described the first generation and uh, second generation antipsychotic toxicity separately, but I combined it because antipsychotic is an antipsychotic, as I said in my previous talks as well, that increased doses of second generation antipsychotics, in increased dose, they become first generation, they become typical. Atypicals become typical when they are in high dose, and even first generation can cause effects, metabolic effects, hyperprolactinemia. So let's take them as antipsychotics and take all the uh, toxic effects. So generally, antipsychotic toxicity is asymptomatic. Patient may present with oversedation, but with the drugs with high propensity to cause QTC prolongation, it can be lethal, and we have seen deaths with overdoses of quetiapine. Same can happen with haloperidol. And again, neuroleptic malignant syndrome can also happen, which we will uh, come after this. So severe extrapyramidal symptoms can happen: akathisia, dystonic reactions, rigidity, tremors. Now it could be an opisthotonus, which is a kind of posture abnormality caused by antipsychotics, or oculogyric crisis, rigidity, tremors. These can happen, and then some acute dyskinesias can also happen, but usually dyskinesia is more tardive and low, slow onset. So acute dyskinesia will be coriform movements, etc. They are relatively uncommon. QTC prolongation and sudden death. This is the most worrying part because you may lose the patient, and that has happened with quetiapine overdose especially. Lethargy and sedation from histamine blockade. Now meiosis, tachycardia, orthostatic hypotension from alpha adrenergic blockade. And tachycardia, by the way, may also result from anticholinergic toxicity. So and if it becomes really very fast heart rate, it may lead to tachyarrhythmias. Anticholinergic toxicity includes confusion, as we have discussed above, in tricyclics, and before that anticholinergic toxicity. So confusion from muscarinic blockade and neuroleptic malignant syndrome, NMS, may happen. Quetiapine can cause respiratory depression as well. It's not only QTC prolongation, but also respiratory depression, depressed mental status, hypotension. So quetiapine is more dangerous. So it, try not to use high dose quetiapine in patients with borderline personality disorder. If you need higher doses, go for other antipsychotics if you have to give in borderline personality disorders, or otherwise keep the dose very low if you're giving in borderline personality disorder, or in any high risk cases. Olanzapine can cause agitation despite sedation, although it is sedating, but it can cause paradoxical agitation, maybe because it's a kind of structurally very related to benzodiazepines. CNS fatigue, lethargy, sedation, agitation, confusion, dizziness, slurred speech, seizure, delirium, coma. Cardiorespiratory or cardiopulmonary, dyspnea, chest pain, palpitations. Of course, if you're causing tachycardia, the heart beating force may be, and hypotension, then the patient will go into chest pain and palpitations and dyspnea because of that. And tachycardia is happening because of both alpha alpha 1 blockade and which is also causing hypotension and tachycardia, and then the other one is anticholinergic effects, which is causing tachycardia. Anticholinergic manifestations: blurred visions, dry mouth, constipation, urinary retention. Gastrointestinal, it is these complications are rare with antipsychotics, but nausea, vomiting, and abdominal pain can occur because the reason is most of the antipsychotics are antiemetics as well. And if you go to the BNF, I think it is written in the BNF that uh, and it is licensed as an antiemetic. So and then again, metoclopramide is a D2 blocker, I think. Domperidone definitely is one. And then Stamatil, prochlorperazine, structurally very much related to antipsychotic. Promethazine is related to antipsychotics. So these are all kind of, they have antiemetic properties, and uh, so they will cause nausea or vomiting very rarely. Seizures can happen. And these antiemetics will come to the NMS, neuroleptic malignant syndromes. All antiemetics can also cause neuroleptic malignant syndrome. Now, CNS, meiosis, ataxia, dysarthria, dystonia, hypotonia, EPSCs, uh, and rapidly fluctuating mental states, depression, agitation, hypersalivation, myoclonus, seizures, coma. And cardiopulmonary. So we've gone through that: respiratory depression, hypotension, could be hypertension in some cases, tachycardia, facial flushing, dry mucous membranes, decreased sweating, mild hyperthermia, gastrointestinal, abdominal tenderness may be there, especially localized to the right upper quadrant, decreased bowel sound. Investigations. So you draw an ECG and you do all investigations which you would otherwise do for a neuroleptic malignant syndrome. You also do blood culture, and if the emergency clinicians think, they may also do a CSF examination, but it is up to them. You should only know the general principles as psychiatrists. So primarily the treatment is supportive, but of course, if the symptoms are more, then only support may not be enough. You have to do something. So airway, breathing, circulation, ECG, monitoring, hypotension to be treated with inotropics, as we said earlier on, cardiac arrhythmias to be treated accordingly, decontamination with activated charcoal or sorbitol, EPSCs with anticholinergics such as benztropine, diphenhydramine, and in Europe we can also use procyclidine. Anticholinergic effects, if they are more prominent, then they can be treated with physostigmine. But if EPSCs are more prominent, then you can treat with anticholinergic. So it depends whether you are treating anticholinergic effects with procholinergic drugs, or you're treating cholinergic effects, or EPSCs with low dopamine effects with anticholinergics. So seizures with here it will be more kind of, there won't be any procholinergic effects, but there may be low dopamine effects in the nigrostriatal pathways and basal nuclei, and you can treat them with anticholinergics if not contraindicated. Seizures can be treated with benzodiazepines, not with anti-epileptics. and try any NMS, treat any NMS symptoms according to the NMS protocol. Now the next thing we have is neuroleptic malignant syndrome. So it generally happens in 2% of the population. And by the way, we are on the slide 29, and we have about 30 and we have about 48 slides, so just 17 to 18 slides left. So yeah, so NMS can happen with antipsychotics or antiemetics. It can happen with sudden withdrawal of levodopa or dopamine dopamine agonists in Parkinsonism as well. Sudden withdrawal. So the withdrawal of levodopa will cause, excessive anti-dopamine activities in all over the body, especially the nigrostriatal pathways, and then it is iatrogenic and it is idiosyncratic. That means it is like an allergic reaction. It's not an allergic reaction, not a hypersensitivity when it comes to the pathological findings of hypersensitivity or allergy or anaphylaxis. It's not like that, but it is a kind of sensitivity or otherwise drug sensitivity. It comes under drug sensitivity, not allergy, and it is an idiosyncratic sudden reaction, and that's why I've included it in the toxicity, although it's not uh, very much strictly, it's not a strictly dose related toxicity. So high doses can often, of course, predispose to it, but there's no kind of a dose response relationship, strict dose response relationship. Even the low doses can cause, and some patients may tolerate even the high doses. And we it's difficult to predict who will get the NMS, but of course risk factors we should try to minimize. If we are giving all the risk factors to a patient, of course the chances will be very high. So dopamine agonists withdrawal or levodopa withdrawal, malignant catatonia can also mimic NMS, and you generally follow the same protocol in malignant catatonia. It is just that you can't prove the the association with antipsychotic. Sometimes without any antipsychotic can happen with malignant catatonia. So and then usually first 2 weeks of antipsychotic therapy. Now we are trying to differentiate it with serotonin syndrome. So serotonin syndrome is much faster. So serotonin syndrome can happen with the very first treatment, but usually NMS may take some time to build up. It can happen with first dose as well if the patient is very much sensitive, but usually it is the first 2 weeks of antipsychotic therapy. It is idiosyncratic. It is after a single dose. So it can happen after a single dose as well. It can happen after treatment with the same agent at the same dose for many years. And that's why some people may think that it's malignant catatonia, it may be NMS, or vice versa. Sometimes you get malignant catatonia and you think it is NMS, it is actually malignant catatonia. So that's why I did not make a separate heading of malignant catatonia, because the symptomatology and treatment, there is a huge overlap. It is just the etiology which differs. And even in the etiology, we are not very sure unless we are very, very clear that there was no antipsychotic involved at all, then we can say malignant catatonia for sure. Now, there's no dose, it's not dose dependent, but higher doses are a risk factor. Rapid dose escalation. Rapid dose escalation can also cause uh, neuroleptic malignant syndrome. That's why we should follow the hyperbolic curve, slow in the beginning and relatively faster towards the end to avoid these things happening. Switch from one agent to another. Again, that can also lead to NMS if it is a sudden. So if you are switching, it can increase to the chances of developing NMS. So switch can also be gradual. Another thing which which is written in the books, and Professor Saad B. Malik, who is a very senior retired professor in Pakistan, he told us years ago that sudden cessation of anticholinergics after antipsychotic withdrawal can also lead to NMS and things like that. So even if you are giving, you have stopped an antipsychotics, just stop it gradually. If the patient is on anticholinergic, continue anticholinergic for another 2 or 3 weeks and then start reducing it gradually and stop it over another 2 to 3 weeks. So it could take about 5 to 6 weeks to safely stop procyclidine after the patient had been on haloperidol procyclidine combination for years. So just be careful, be very slow and gentle in any change. Parental administration is also a risk factor, and here it is the first dose which can cause NMS. That is why it is discouraged to give IM haloperidol in an otherwise drug naive patient. Try the orals first, try the benzodiazepines first. If the patient is not known to you, do not rush to antipsychotic parenterally. Try with the oral antipsychotics plus uh, injection. If you have to give anything injectable, it could be promethazine or lorazepam. But try not to give the parental administration to drug naive patients, not parenteral antipsychotics, and do not give zuclopenthixol acetate as an acute measure for rapid tranquilization in any cases. Acetate should be given only in patients who have received many doses of rapid tranquilization, many doses of haloperidol, and it's not working. Then you can give it as a semi-depot. So it is a semi-depot. It's a medium-acting depot injection which can work for 3 to 4 days, but it's not a rapid tranquilizing injection. Now, two of the four cardinal features, if you are having in the ABCD criteria, if you are having two symptoms, you can say that it is NMS. And this and in any classification, DSM-5 or ICD-10, the rule, or ICD-11, remember the rule of half. It's the rule of thumb. If you have half of the symptoms or more than half of the symptoms of anything, you can diagnose most of the conditions. That's a general rule, but exceptions are there. So here it is hyperpyrexia or hyperthermia. Some sources say hyperpyrexia is a very high grade fever. Some sources say hyperthermia is just a high grade fever, or a fever, just fever. So more commonly, but hyperthermia occurs more commonly with first generation antipsychotics. Dysautonomia, autonomic disturbances like tachycardia, labile or high blood pressure, tachypnea, these can happen. Arrhythmias may occur. Diaphoresis is most often profuse, so very marked sweating. And rigidity can also occur. Lead pipe or cogwheel rigidity. Dystonic reactions or crises such as opisthotonus or oculogyric crisis, chorea, dyskinesia, sialorrhea or dysphagia or tremor. So rigidity, EPSCs, but they are not typical EPSCs. They are very, very severe extrapyramidal symptoms. This is one of the four symptoms in the criteria. And the fourth symptom, and you need two out of those four symptoms. So the fourth one is mental state changes, commonly confusion, but there can be catatonic mutism or other catatonic symptoms as well. So, uh, so it could be either confusion or catatonia, and especially catatonic mutism in mental state changes. And if it is malignant catatonia, it's more likely to be catatonic symptoms, although confusion can occur in both, and catatonia can occur in both malignant catatonia and NMS. Investigations, CPK or CK, uh, I think in America you call it CPK, in UK and Ireland it's called CK, creatinine kinase. So UNDs, acute kidney injury or acute renal failure picture from rhabdomyolysis, because when it is more and more lead pipe rigidity, cogwheel rigidity, tremors, it will lead to muscle damage. The muscle proteins will go and accumulate in kidneys, and that can cause acute kidney injury or acute renal failure. Electrolytes may be markedly deranged, hypocalcemia, hypomagnesemia, hypo and hypernatremia, hyperkalemia, metabolic acidosis. Full blood counts you have to have, and then lactate dehydrogenase. LFTs can be deranged, such as alkaline phosphatase, ALT, AST. Urine for myoglobinuria, because because of this marked very severe EPSCs, you're getting muscle damage. Myoglobin from the muscles will be excreted in through kidneys into the urine, and you can detect it as a myoglobinuria. That can also lead to acute kidney injury. Serum iron can be low. Complications of NMS. So dehydration, electrolyte imbalance, acute renal failure with rhabdomyolysis, cardiac arrhythmias can happen, torsades de pointes and cardiac arrest because of the antipsychotic toxicity, if they are associated with high dose antipsychotics, but otherwise not. Myocardial infarction can also happen as a uh, as a complication. So cardiac arrhythmias can happen, myocardial infarction can happen as a complication, cardiomyopathy, respiratory failure with chest wall rigidity. Patient is unable to breathe because the chest muscles are not moving due to the severe dystonic reaction and severe spasticity. So aspiration pneumonia can happen, pulmonary embolism can happen, and that can result in respiratory failure. DVT, deep vein thrombosis, can occur, thrombocytopenia, DIC, DVT, seizures from hyperthermia and metabolic derangements can occur, hepatic failure, sepsis, and that's why you do blood culture to outrule sepsis, because there will be a leukocytosis here. So treatment is so in FBC you can see leukocytosis. Treatment is stop causative treatment agent, give supportive treatment, rehydration, monitor blood pressure, treat and prevent complications accordingly, lower the fever, usually by the hypothermic cooling measures, but not usually with antipyretics. But again, the patients are generally treated in the ICU, and it will be the ICU clinicians who will decide what to use in these cases. So lower or maintain blood pressure accordingly. Clonidine can be given if the patient is hypertensive. If it is hypotensive, then not. Nitroprusside may also be given in some cases. Heparin, low molecular weight, heparin, muscle relaxants, dantrolene, bromocriptine, amantadine, benzos to prevent seizures and to reduce the muscle tone and rigidity. So and to overcome the agitation. So diazepam, lorazepam. ECT can be beneficial in both malignant catatonia and NMS. Prognosis: most episodes resolve within 2 weeks, and residual motor symptoms of catatonia may persist. Restarting the antipsychotics after NMS. So uh, wait at least 2 weeks before resuming therapy, or longer if any residual, if any clinical residue exists. So you should wait at least for 2 weeks before restarting, and then after you're using restarting, go with another agent. And if you have given typical antipsychotics, go with the atypical second time, and with lesser propensity of the causing the extrapyramidal symptoms such as quetiapine. So use lower rather than higher potency drugs. So again, quetiapine is a low potency drug, because you can go, the doses can go in hundreds of milligrams. And risperidone and trifluperazine, they are high potency drugs. So give anything with the low potency, which can go in, which the dose range can go into uh, something like hundreds. Avoid concomitant lithium after NMS. That's another point which the authors say. Avoid dehydration, and careful monitoring of symptoms of NMS is required. So now the next topic is psychostimulant overdose, and we have just three more left: 9, 10, 11. So psychostimulant overdose, and we'll fly through it. So it can lead to sweating, hypertension, tachycardia, severe agitation, psychosis, hyperthermia, mydriasis. Cases may be asymptomatic, uh, or they can be in, patient can be in a sympathomimetic crisis, which will be similar to anticholinergic crisis, I would say. And it can result in imminent cardiovascular collapse. uh, Investigations: glucose, ECG, uh, and aspirin levels, and paracetamol levels, like acetaminophen levels and salicylate levels, to rule out the paracetamol and aspirin toxicity. Treatment is ABC benzos, cooling measures for hyperthermia, sorry for the typo, nitroprusside and phentolamine uh, can be given to bring the blood pressure down. And then anticoagulant poisoning, another thing which is relatively uh, common in the Asian countries. So anticoagulants, which is like the rat poison, which is easily available in Asian countries, and it can be very much lethal. Here there are restrictions in UK and Ireland for selling, and uh, in my experience, the over-the-counter rat poison does not kill any rat, and they hardly kill any mouse even. They're very, very weak, and you have to call the companies, the contractors who will come and put the powerful drugs, because they are only licensed to use the powerful anticoagulant drugs. And the ones, the sold ones sold in the open market, they're very weak, and it's just to prevent the human beings. So yeah, it can be no symptoms to excessive bleeding depending on the dose taken and depending on the strength. And treatment is decontamination with activated charcoal, referred to hematologist. 4-factor prothrombin complex concentrate can be given by hematologists. Serotonin syndrome is the final thing. So, and we'll give it, this is the last topic of today, and we'll try to differentiate it with the neuroleptic malignant syndrome and cask candidates. It can come in the casks as a cask station at any time, and it may have come already, because I'm not very up to date which stations have come. So uh, just uh, so just listen very carefully. So it starts with nausea, vomiting, and diarrhea, which can be the prodromal symptoms. So if the nausea, vomiting, and diarrhea are occurring, especially diarrhea, then be careful in increasing the dose. Uh, and vortioxetine invariably causes nausea, vomiting. I don't know about diarrhea and with the very first doses or not, but just be careful. That's the lesson. So, shivering, hyperreflexia, myoclonus, and ataxia, rigidity, hyperthermia can also be there, but it is less severe than in NMS. And again, even in NMS, if NMS is happening due to the atypicals, there will be less rigidity and less hyperthermia. Hyperthermia, agitation, ocular clonus, tremor, akathisia, deep tendon hyperreflexia, inducibles, spontaneous clonus, muscle rigidity, dilated pupils, dry mucous membranes, increased bowel sounds, flushed skins and diaphoresis, neuromuscular uh, abnormalities are more pronounced in lower limbs, and then occurs within 24 hours. So here, and I will, don't be like, don't worry about this symptom complex I've read through. We'll try to develop something in the next slides, how to uh, how to remember the symptoms of serotonin syndrome. I have tried to develop a very good mnemonic, which will come in the next slides. So it occurs within 24 hours or even mostly within 6 hours of a change or an initiation of a drug. And drug is usually serotonergic drug. So that is one of the differentiating point with NMS. NMS is more subacute and chronic, like chronically developing or subacute. I won't say chronic, but it is more subacute generally. But it can be chronic, like it can occur after months use and a sudden reaction after several months. But here, so I'm talking about NMS, but in serotonin syndrome, it is more acute. It will occur mostly within the 6 hours or within 24 hours of initiation of a drug or a change of a drug. That's why cross tapering should not be very abrupt. It should be relatively slow to prevent this happening. Hunter criteria, again, you don't have to rote learn it. It's a bit complex, so but I will just read it. I will come to the mnemonic, and that is more kind of easier to remember. Hunter criteria is serotonergic drug plus, so you have given us serotonergic drug plus one of the following: spontaneous clonus or inducible. So spontaneous clonus is that the ankles or the knees are having clonus like that spontaneously. But inducible clonus is something that you kick, like a motorcycle kick or something. So you put a kick to the ankles or to the knee, to the patella, and then that clonus is more inducible clonus. So these things are not seen in NMS. Here, clonus is more seen in this serotonin syndrome. And in NMS, there are more tremors and hypertonia. Here, so things are more tonic there, and here things are more clonic. So inducible clonus and agitation diaphoresis. So inducible clonus plus agitation or diaphoresis. And only one of these four. So it can be just this one, or it can be these two symptoms. Two symptoms here. One plus either of these. Again, one plus this or this. So again, if there are two symptoms only for here, only like we want only one. So if there is ocular clonus plus agitation or ocular clonus plus diaphoresis, you can diagnose serotonin syndrome. Similarly, if there are tremors plus hyperreflexia, both, you can still diagnose the serotonin syndrome. But you, of course, you'll be more cautious to rule out NMS in this case, because these things can happen in NMS as well. So you'll go with the other symptoms of neuroleptic malignant syndrome. Hypertonia plus hyperthermia plus now ocular clonus or inducible clonus. So here there are three things. If these three things are together, hypertonia, hyperthermia plus clonus. So whether it is ocular clonus or induced clonus, you can still only with this whole thing you can diagnose serotonin syndrome. Now the mnemonic which I came up with is Scotch Brite, and Scotch Brite is a if you go to the kitchen and you may come across, it's like a sponge, or it's like something, a cleaning fabric for the cleaning of utensils, and it's a very very famous brand. So Scotch Brite. So S for shivering, seizures in advanced stages but not usually. Shivering, Clonus, C for clonus, induced and spontaneous both. C for coma and death, of course, if the case is very advanced. O for ocular clonus, T for tremor, C for spontaneous clonus, clonus spontaneous, H for hyperthermia, hyperreflexia, hypertonia, B for bowel sounds increased and maybe diarrhea and spasm, etc. And then R for rapid switch between pulse and blood pressure. So some dysautonomia which can be there, and it can be an overlapping symptom with the NMS. Reflexes are increased. Again, we said hyperreflexia, but you can say R for reflexes as well. And rhythm of the heart abnormalities. Again, there's a typo. So heart rhythm abnormalities in advanced stages, not usually otherwise. And irritability means akathisia, agitation. Again, irregular heart rhythm. I've come with I. And then TE, Scotch Brite. So rhythm disturbances in advanced, irregular rhythm in advanced stages. And T for tendon reflexes increased, temperature increased. E for excessive sweating or diaphoresis. So just remember this mnemonic, and if you want, I can send you. Investigation, same as in NMS, but consider LP, CSF examination, blood cultures in both conditions. Treatment is discontinue serotonergic drugs. Benzodiazepines can be given both for agitation and neurological side effects in the same way as in NMS. So, and also the autonomic abnormalities, it can be treated with benzos. Oxygen, IV fluids, cyproheptadine is an antidote to the serotonergic drugs, so that can be used in some cases. Medics can decide if they want to use intubation in very severe cases, cooling measures, but avoid antipyretics. And I think we have finished. So, any questions? Any questions, anyone? Okay. So yeah, thank you very much for listening. If there are no questions, Dr. Candy? No?
No. I just want to say thank you. No.
All right. Thank you. All right then. Thank you.
Thank you, doctor.